So my presentation today is tongue-tied, best practice for management of ankyloglossia. And I have nothing to disclose. Some objectives for today, really understanding recent trends and implications in diagnosis and treatment of ties, understanding current controversies and consensus guidelines for diagnosis and treatment of ankyloglossia, upper maxillary frenulum tie and buccal tie. And we're going to talk about all of these in detail. And then understand frenulectomy procedure, post-op care, and possible complications. And, I think this is a very hot topic right now, but a little interesting backstory. Frenulectomy as a procedure was actually first, thought to be relevant going way back to 1600. In 1601, Louis XIII was born. He was a royal, and his surgeon, a royal surgeon, actually was reportedly did a tongue tie procedure to facilitate breastfeeding in him. So that's kind of the first reported documentation of frenulectomy. And then in 1679, there was a textbook that was published and kind of had these wood carving pictures of an infant having a frenulectomy procedure. And, that is kind of the first written documentation in a textbook that we have. And then in the 1700s, there is also a lot of depiction that these 18th century midwives kept one fingernail very long in order to actually facilitate doing a frenulectomy after birth and helping with breastfeeding. So, this is something that goes way, way back. But in the 1940s and 50s, historically, mass-produced formula kind of became the norm. There was a big decline in breastfeeding, and therefore procedures kind of went, diagnosis and treatment of ankyloglossia kind of went by the wayside. And then it was really in the 1990s that we had this resurgence of popularity with breastfeeding. There's a lot of campaigning around that time. The American Academy of Pediatrics started, producing some literature on and guidance for breastfeeding. And this Breast is Best campaign was a, big part of the resurgence of breastfeeding. And naturally that led to increase in diagnosis and treatment of ankyloglossia. But I think as all of you are aware, and why I think this talk is relevant, and a lot of people frequently ask about this, why has there been such an increase in the diagnosis and treatment of ankyloglossia, truly exponential increase in recent years? Between 2003 and 2012, and between 2012 and 2016, the otolaryngology literature, the same group actually really took a deep dive into this, and they looked at trends in inpatient diagnosis and management in the US in that 1997 to 2012 timeframe. And then they looked again from 2012 to 2016. And between 2003 and 2012, they found a fourfold increase in diagnosis of ankyloglossia and a fivefold increase in the number of interventional procedures that were being performed. But then between 2012 and 2016, there was this 110% increase in both diagnosis and interventional procedures, which really is crazy to think about. And, we are seeing a lot more of this. I think there's a lot of information out there, and the question is, what should we be doing as much diagnosing and intervening as we are? And this is a chart from the second paper, 2012 to 2016, and the top is showing the diagnosis of ankyloglossia by year. The bottom is showing the lingual frenulectomy performed by year. So we really are seeing that exponential increase starting in the late 90s, but this red line and star marks 2012, where we see this crazy increase. An interesting thing, that we see that happened in 2012 was the American Academy of Pediatrics updated their guidelines for breastfeeding, and that was really when the emphasis came out that we should be focusing on exclusive breastfeeding in the first 6 months of life and longer as determined appropriate and by the relationship of the infant and the mother. But that was a big thing that happened in 2012 that I do think was part of the impetus, which is a good thing. We are encouraging breastfeeding, and for good reason. But so that kind of, touches on the increased focus on benefits of breastfeeding, and that is a reason for increasing diagnosis and treatment. I think there has also been this increased awareness that ankyloglossia can potentially affect breastfeeding, and some of that does come from physicians and the medical literature. but there is a large media focus, a large social media focus, a large online community focus that are really pushing this as a huge problem and something that we should be addressing. And those are some of the reasons that we're really seeing increased diagnosis and treatment. This top right picture is a New York Times article that came out several years ago that, really opened up the fact that there unfortunately are a lot of clinics and specialists out there that probably do have some more economic incentives, and they're just recommending this procedure to be done on everyone. And a lot of providers, and it was lactation consultants and surgeons that were kind of, looked into and lost their licenses due to kind of extreme recommendations and kind of performing unindicated procedures on infants. So I think there's a lot of negative press that has come around this, but you can see the picture that came from this article, this exponential increase also in just Google searches that people are doing at home with the term tongue tie. So this is huge on social media, TikTok and Instagram. You'll see videos running rampant about this. And there's a lot of online communities, tongue-tied baby support groups that parents can join. And there's a lot of pressure, I think, from parents to have this procedure. But the question is it really indicated? So with this exponential increase, the American Academy of Otolaryngology and Head and Neck Surgery really was the first organization that was like, we need to look into this, and created consensus guidelines in 2020, kind of looking at all the data and determining, when should we be diagnosing this and when should we be intervening. And then other academies came along in the years following. The Academy of Breastfeeding Medicine published a position statement in 2021. The American Academy of Pediatric Dentistry published consensus guideline in 2022, and then the American Academy of Pediatrics updated and produced identification and management of ankyloglossia and effects on breastfeeding in infants in 2024. So really what I'm going to be talking about through the rest of this talk is just what these consensus guidelines kind of all agree on, where some of the disagreements or controversies arise, but I do think these 4 documents are excellent. They all are very concise, and I think all pediatricians should definitely consider looking into these 4 guidelines, just for guidance and management. But I'm going to kind of summarize what they are saying. So something to kind of focus on, starting off is symptoms. So what are symptoms of ankyloglossia or lip tie? And this actually comes from a blog. So you'll see on the left-hand side is baby symptoms, on the right-hand side is mom symptoms. And there are a lot of vague symptoms that a lot of newborns have. So colic and irritability, coughing, choking, gulping during feeds, difficulty latching, drooling, being gassy, making a clicking noise, poor weight gain, reflux. These can all be symptoms that are attributable to tongue or lip tie, but all of these can also be attributable to other, pathologies that are causing difficulties with feeding. And same with mom, not all mastitis is caused by issues with breastfeeding. The one that we really do feel like symptom that is indicative of difficulty with breastfeeding is pain, blistering, bleeding, that's like persistent, but initially getting used to breastfeeding, there is some pain, blistering, bleeding that's associated with that. So it's kind of looking at these symptoms, but kind of in a bigger picture. On the otolaryngology side and kind of our focus, we really think of 3 potential implications for intervening on ankyloglossia, and that is breastfeeding issues, speech issues, or mechanical and social issues. And we're going to talk about each of these. So breastfeeding in baby typically looks as difficulty latching, colic, gas and reflux, or poor weight gain. Mom, one thing that we're focusing on is nipple discomfort. Difficulties with breastfeeding, like I said, are common, but they might not always be attributable to some type of oral cavity tie. So it really is important to consider a really thorough history, a really thorough physical exam. If there are any other concerning symptoms, such as nasal obstruction, mouth breathing, concerns for airway obstruction with stridor, any irregularity in the breathing pattern, signs of reflux, or if there's an underlying syndrome or craniofacial anomaly, it really is important to consider, I would say, otolaryngology referral to kind of rule out some of these other causes of issues with breastfeeding before, considering intervening or referring a patient for intervention of ties. And ideally, infants should be evaluated by a lactation consultant prior to surgical intervention. I do think this is happening fairly commonly in the nursery setting before discharge. And if there is any, mild difficulties with breastfeeding, I think typically the lactation consultants will recommend continued outpatient follow-up. And if there's not progress being made, then it's, considering referral is considered. I think speech is another big thing. Obviously, in the newborn population, they're not able to talk that early, but ankyloglossia does not typically affect the ability to develop speech. It does not cause speech delays or any other problems. The primary concern is future issues, specifically with articulation. So babies will still develop and toddlers will kind of progress and develop speech, but later on, there might be a observation that there are difficulties with articulation, and certain sounds do require the tip of the tongue moving on the teeth. So if that tongue is tethered in any way, they're not able to say words correctly. And I interestingly have seen a really high number of Spanish-speaking, in the Spanish-speaking population, a number of kids around school age, 3, 4, 5, and they aren't able to roll their R's, and they do have some degree of ankyloglossia or tongue tie. And releasing that really does help with their ability to articulate, but also just rolling their R's, which is expected for speaking Spanish. But older children that are having any speech concerns should be evaluated by a speech therapist before considering surgical intervention. For mechanical and social issues, these are all theoretical future concerns, and we typically don't recommend intervening in mild cases, consideration of moderate severe cases, and we'll talk a little bit about that. But if your tongue is significantly tethered, you're unable to lick foods or your lips, it can cause difficulty with keeping the teeth and the oral cavity clean, because if your tongue is not able to reach within the commissures, upper and lower commissures, the front and back of the mouth, you can't keep the oral cavity clean of food that gets stuck in various places, and that can cause social, embarrassing situations, and it also can cause teeth decay and other problems. Inability to stick out tongue or French kiss is also something that I personally have seen in clinics where patients have been referred by someone or the parents that are up in arms over this in teenage patients. It's very interesting. And then the space between the central incisors, what's called the interincisal diastema, is something that comes up a lot in the pediatric dentistry literature, where as their teeth grow in, is there going to be a big gap between the teeth? So we'll talk about these things with diagnosis. So ankyloglossia is more commonly known in, I would say, our patient population and families. They know this as tongue tie. And this is a true diagnosis. It's a first branchial arch anomaly. This results from the persistence of the embryologic band that connects the anterior tongue with the medial surface of the mandible. So in very severe cases, this can have pretty significant restriction in the mobility of the tongue. The anterior tongue tie diagnosis is very widely accepted. The posterior tongue tie is very controversial. We'll talk about this. The incidence of ankyloglossia in the infant population is between 3 and 10%, and it has been increasing in recent years just due to broadened definitions that are out there, and therefore increased diagnosis. And there is a slight male predominance that we see. The unfortunate thing is there really truly is a lack of standardized diagnostic criteria. There's a consensus that a lot of infants and children are being overdiagnosed and having unnecessary surgery, and that is definitely something that we are aware that's been happening. There are multiple classification systems that have been made to kind of help clarify some of this, and we, as otolaryngologists, focus more a little bit on the anatomic location system. So the Carollo's classification and the Kotlow classification are two that have been created. A lot of lactation consultants and speech therapists will look at the function classification system. So specifically, the Bristol tongue assessment tool was made later, and it was a shorter condense, but validated just as much as the Hazel-Becker assessment tool, which was the first tool that was created. It's pretty long and extensive. But I do think speech therapists and lactation consultants typically will use this as part of their assessment and consideration of referral. So this is this classification system, the Krolos on the top and the Kotlos classification on the bottom. The it's kind of reverse. So type 1 in the Krolos is going to be your very severe cases, whereas type 4 in the Kotlo is going to be your severe cases. So they're kind of inverse in severity, but these are basically looking at the attachment point of the tongue. Where on the tongue is it being attached? Kotlo is looking at a distance. Korlos is looking kind of a more vague positioning without the measurement. And this is a picture just showing our Korlos. The Kotlo is in parentheses, so it's the reverse diagnosis. And this top left is going to be your really severe cases where the true tip of the tongue is tethered, and that's going to cause very severe restriction. This type 2 is also going to likely cause some pretty significant constriction or restriction of movement, which can have implications for feeding and for speech in the future. This type 3 Korlos or type 2 Kotlo is kind of where it starts to get a little bit more vague because we all do have a frenulum, and I'm going to touch on that, but you can see that the tip of the tongue has pretty free range of motion. And then this type 4 is kind of getting into the gray area where there's really no true frenulum. We just see maybe some palpation of thickened tissue there, or maybe a more strong protrusion of the muscle. And these are those assessment tools, the Bristol tongue and the Haselbecker assessment tools that our colleagues will frequently use, but it's basically just looking at the shape of the tongue, the attachment, and some of these other things. But it's a pretty helpful assessment, and based on the number that is scored, there's correlation with impairment of function. So I think the first hot topic is anterior posterior tongue tie. A lingual frenulum is a normal anatomic structure formed by a fold in the layer of fascia that spans the floor of the mouth. So anterior tongue is a very widely accepted diagnosis, and those are those pictures that I showed you where you have tethering of the tip of the tongue. But as you get into the presence of a frenulum more posteriorly in the back of the tongue, that is considered a very mild or non-existent anterior tie. Posterior tongue tie is controversial. Most people think of it as a density of the underlying genioglossus muscle. There's no consensus from the American Academy of Otolaryngology, American Academy of Pediatrics, or the American Academy of Pediatric Dentistry on the definition of posterior tongue tie, and we recommend not diagnosing that. It can be a mild anterior tie, but we really don't recommend using the term posterior tongue tie. This is an interesting article that looked at the histology in cadavers of floor and mouth specimens. And what they found is that the floor of mouth fascia and overlying mucosa is what forms the roof of your sublingual space. There's not a distinct cord or band that is the frenulum. It really is just a protrusion of the fascia that kind of balls together when the tongue is elevated. But they do see that there's variation in thickness and composition of the fascia. Various amounts of collagen and elastin can make up the composition, and that is possibly what's causing the variation in distensibility, which can explain why some people are maybe more symptomatic for a mild tie compared to another patient. But what we recognize clinically as the lingual frenulum is this contour of the floor mouth fascia with tongue elevation. And then the genioglossus is variably positioned within that muscle. So sometimes we see it more predominantly, sometimes it's more recessed and you don't see it within the fascia. But the lingual nerve branches are also found right underneath that fascia. So that's important in talking about intervention because we don't want to have, sensory deficits. The upper maxillary labial frenulum is known as upper lip tie. This is attaching to the central portion of the upper lip between the central and maxillary incisors. It provides stability for the upper lip. It is a universally present normal structure, but it does have variable anatomic positioning. There is no consensus on the relationship to the upper lip with breastfeeding difficulties. It's always something we can talk about. The consensus recommendation according to American or the Academy of Breastfeeding Medicine is recommendation against release of upper maxillary lip frenulums. And then from the American Academy of Pediatric Dentistry, they talk about the alveolar ridge and the positioning of the frenulum on the alveolar ridge, because if it's a very, very thick frenulum, greater than 2 millimeters, the diastema likely will not close spontaneously. So they recommend releasing it to prevent potential future issues with gap in the teeth as they come in. But the alveolar ridge typically does descend away from the frenulum and will stay in place. So there's not great evidence that in these more mild cases, the persistence of the upper maxillary labial frenulum will cause future issues with gap teeth. And this can always be addressed in the future when patients are undergoing orthodontic care. So preemptively releasing it in our newborn population typically is not recommended. Buccal ties, this is more commonly known as cheek ties, and this is a perceived tightness in the maxillary or mandibular buccal frenula, which is between the alveolar ridge and the buccal mucosa, and it helps the buccinator keep fluid boluses between the teeth. This is very strongly felt to be a normal structure, and all the guidelines listed here recommend against releasing buccal ties because there really is no advantageous benefit. The American Academy of Pediatric Dentistry doesn't make any comment on it, but it is recommended against releasing buccal ties. So, what patients should be referred for consideration of frenulectomy, kind of summarizing some of these things. Any breastfeeding difficulties, we would recommend a lactation consultant referral if that has not already been done in the inpatient setting or in the nursery, and frenulectomy referral to consider releasing of ankyloglossia. It's kind of a discussion with families about the upper maxillary labial frenulum and if that's something that we should intervene on. The downside is that really is harder to release at bedside or in the office because there's a lot of muscle fibers within that upper frenulum. So releasing it the same way that we release a tongue tie is not typical. A lot of clinicians will use lasers. We don't typically use that in the ENT world, but lasers at least have the ability to burn and cauterize tissue at the same time as cutting it. And I think that's why maxillary lip ties are released more commonly by providers with lasers, because it can be done in the office. Moderate severe ankyloglossia, however, though, it is reasonable to consider intervening in infancy for prevention of future articulation issues, future mechanical issues, or social issues. And then very severe upper maxillary frenulum that greater than 2 millimeters, theoretically releasing that could prevent a future diastema, but it could also be done in the future. But we do not recommend referring for frenulectomy if they're not having any breastfeeding difficulties, if it's mild ankyloglossia to prevent future feeding or articulation issues, the mild lip ties in classes 1 to 3 to prevent future feeding or diastema. We do not recommend releasing buccal ties, and there's a lot of, I think, social media presence saying, oh, releasing ties is going to treat obstructive sleep apnea or other related symptoms, and there's no evidence that that is indicated. But just to note, frenulectomy can be performed at any age if concerns arise. Typically, at least in our practice, under 6 months, we are able to do awake in office procedures. Greater than 6 months, we typically need to have a little bit of sedation on board. And we do have, I think, a higher number of patients that get referred due to incomplete resections in the office because an older patient's using a laser. If they're moving, they're not able to get as deep of a cut, and sometimes that leads to incomplete resections and need for revision surgery. So what does surgical intervention look like? In short and sweet, the lingual frenulum is cut. And how do we do that? In office, in our younger patients, the patient is typically swaddled. We give them sugar drops pre and post procedure for comfort, and then we encourage breast or bottle feeding immediately after the procedure. Less than 6 months, we do isolate the frenulum with a groove retractor. We put a hemostat across it for approximately 30 seconds and then cut it with scissors. And the posterior limit is that genioglossus muscle. And that's why we don't recommend, treatment of posterior tie, because that typically involves cutting through the muscle underneath the frenulum. And that can have effect on sensory, more likely to have sensory effects because we're getting into those lingual branches that live in the muscle themselves. Procedures in greater than 6 months, this is typically performed under sedation. We will use bovicautery sometimes, and we will consider suture placement as well. This is a kind of a picture of what we typically see pre and post. That fascia divides, we see the muscle underneath. That will heal on its own. Sutures can be placed to reapproximate this mucosa to help with healing, but we don't do that in our newborn population in the office. In older kids in the under sedation, we'll consider doing that. Post-op care, we recommend continuing the normal feeding regimen. There are no indications in the literature now. They're realizing doing stretching and massaging doesn't really affect the healing, so we don't really strongly recommend that. Just normal mobility of the tongue through feeding is enough to keep the tongue mobile and from fully, like for rescarring or anything like that. And any sutures that we use will dissolve in 7 to 10 days. Complications are typically minor. It's a well-tolerated procedure. Bleeding, pain, oral aversion are all rare but possible. Same with scarring. Going into the muscle underneath the frenulum and releasing of this posterior tongue tie that I know some clinicians will do has a much higher risk of scarring, sensory deficits, injury to the salivary ducts, formation of mucoceles, pain, oral aversion. So we really don't recommend more aggressive intervention. Results, we typically tell families will continue to improve up to 1 month post-op. This is kind of what patients look like pre and post. The right is a more extreme example. The left is more typical in our infant population. A mild recurrence of frenulum is normal because, like I said, the frenulum is a normal structure. The frenulum is attached and it is basically just fascia. So the mouth has to heal and reform that frenulum. The idea is just that it's significantly less tethered than it was previously, but you might, lose a millimeter or two of tongue mobility in the healing period from the day of the procedure, and that is expected. Very few patients require revision if performed in infancy or under sedation. But like I said, if incomplete resections are done with a laser and the patient isn't able to stay still and they're not able to do a complete resection, then we're more likely to see revision requirements. And I think I'm right on time. So I thank you, and I'll take any questions.
Yep, thanks, Dr. Levin. So, what percentage of these are performed by you all versus like private pediatricians?
That's actually a great question because I do know it seems like there's a big variation in terms of pediatricians that will perform this in office. I think in our really young patients, less than a month old, in their first couple newborn checks, I do think there is a fair number of pediatricians that will do this. But as the patient gets slightly older, even, months up to 6 months, they're a lot more squirmy. The bleeding risk is slightly higher, and we have silver nitrate that we use in the office sometimes to manage any bleeding. So I think if it is a thicker frenulum, I would probably recommend referring to us just because there's probably a slightly higher chance of bleeding. And I don't know that all pediatricians are able to address that in the office. But the very thin frenulums in our newborns, I think pediatricians are addressing it. But I'm not actually sure what percentage of pediatricians are doing this, and I would be curious to know that.
All right, appreciate it. Thank you very much.
Thank you.